Okay, so the last thing I want to talk about in these show me's is I want to talk about pulmonary embolism. From now on, I will just abbreviate that to PE, pulmonary embolism or pulmonary embolus. Uh, yeah, this is a hard one, guys. Uh, it's relatively tough to say for sure that your patient is suffering from a pulmonary embolus, just in terms of a field diagnosis. But here's another area where something is really important. History, patient history. Patient history is going to maybe give you your best clue as to whether or not this patient is suffering from a pulmonary embolus. Now, if your patient walks to the door, they're blue or purple from the nipple line up, and they fall out right in front of you, they collapse, and they go into cardiac arrest, well, you have a bigger problem than trying to figure out whether or not this is exactly a pulmonary embolus. Probably is, but you have a bigger problem, right? You got to work that patient. Anyway, let's talk about the patient that presents with a potential pulmonary embolism. And we're just talking about, that they had a recent history of maybe trauma or maybe even surgery. Or maybe they had childbirth, right? Again, and there's more. There's et cetera. There's more in here that we could be talking about, but let's talk about really the signs and symptoms of pulmonary embolus, and then really what our idea is for managing pulmonary embolus. Some pretty obvious signs and symptoms of pulmonary embolus. The patient is going to have trouble breathing, right? So shortness of breath, that's a given. But then adding to that this patient will really, really be anxious, maybe even more so than what we normally see with our patients that are having respiratory distress. So they have really, really, really bad anxiety to go along with that. But all of the other stuff that we look at, it just, nothing is really pointing to a respiratory issue, right? So you look at their lung sounds, they're usually clear. Oh, there's times that there's pulmonary embolus patients that have some rales or something like that, or wet lung sounds or whatever. There's that potential, but in general, no. You may see that in their sputum, if they're able to cough, because most of the time they're going to have a non-productive cough. But if they're able to cough and they get some production out of it, you may see blood. You may see some blood or some blood-tinged sputum. So really the problem here with your pulmonary embolus patient on terms of VQ mismatch here, they're more over here, okay? They're able to ventilate. They're actually able to breathe. They're able to get air into their lungs and out of their lungs. They're just not able to get it to where it needs to be. And that's because they've got something blocking that vasculature. So that's what your pulmonary embolism really is it's a blocking in that vasculature, okay? Well, in your really, really severe pulmonary embolus patients, you could see that you have some changes in their skin. So they say purple from the nipple line up, or so purple. Say purple head, right? That's relatively that's kind of rare, but it's out there. It's out there. It's kind of rare. I really don't see that as much. You might see some of these patients become hypotensive, so their blood pressure could be low. Their heart rate to begin with is usually high, big surprise. And then, you know what? If they become bradycardic, oops, no, Bill's not happy. Let's not draw that. If they become bradycardic, Bill's not happy, right? Because these patients are potentially decompensating. Really, your treatment for these patients needs to be high flow too. So as much O2 as you can get to them. And if you need to do positive pressure ventilation, right, so you need to use the BVM on these patients, that is a possibility. I generally would avoid CPAP with these patients. More so, I would go with my positive pressure ventilation. So positive pressure ventilation on these patients, potentially intubating these patients, that's where we're probably going to be. Now, there's an interesting issue here, right? If they have a backup in that circulatory system, if they have a backup in the system going to the lungs, right? Right, so what's going to happen then is the fluid and the blood is going to start to back up into the right side of the heart, okay? And it's going to back up into this right ventricle, right? And what we're going to see is that that right ventricle is going to get bigger. That right ventricle is going to have to get meatier and bigger, okay? Not that the right ventricle is going to really grow, because the right ventricle is not going to grow, right? The right ventricle is not going to grow, but it's going to get fuller. It's going to get fuller. It's going to expand. This whole right ventricle is going to expand, okay? Because we're going to have this backup into that right side of the lung. Well, that's called cor pulmonale, that really extensive expansion of that right side of the heart. And so obviously you can see sort of the problem here is that we're going to do something to preload, right? We're going to actually wind up decreasing the preload because the blood that's coming back into the system is now not really going to have anywhere to go. It gets backed up. And so we're going to lose that preload, and ergo we're probably going to lose that afterload too. And that's what's going to lend me to probably, seeing that low blood pressure and that high heart rate. So we're going to start to get that massive backup there into the lungs, into the right side of the heart. And that's really, really an issue. Okay, and the way I drew it, it maybe looks like the myocardium is growing. That's not really true. That's not what's happening here. That happens in something different. We'll talk about that later on. But what's happening is that right ventricle is getting more full. Okay, there's less blood that's able to come back now to that right side of the system, that low pressure pump, because there's a backup. Okay, and so that's what you're starting to see with your pulmonary embolus patients. So there is the possibility of having JVD, jugular vein distension, which means that flow coming back from the head is impeded, right? And that's why you see that change. That's why you see that change in the color of the head and the face. And you can say head, you can say purple head and face. Okay, so you could be saying that, and that's what's happening here is that you're getting this jugular vein distension because there's backup here, and this superior vena cava coming off here like this is the blood is actually backing up in that superior vena cava, and that area is going up to the head, and so blood is sort of backing up. You're not able to empty properly. So yeah, that's what you're looking at usually with your patients that are pulmonary embolus. And you may see some blood, if you intubate these patients, you may see some blood coming up through the tube and stuff like that. Generally, if there's a lot of blood in the tube, your patient's really in a rough in a rough spot. And the chances of that patient really having survival is pretty low if they've got a ton of blood that's coming up into the tube. So really what I'm referring to right now is pulmonary embolus in the vasculature, and I'm thinking more blood clot style backup. We'll talk about some other potential causes of pulmonary embolus a little later on, more into the trauma section. We'll talk a little bit more about some potential causes of pulmonary embolus, but that's where we're at for now on pulmonary embolus. Hope you enjoyed it, and talk to you later.